Chapter, dear Roberto Saldivar, dear ladies and gentlemen, my most cherished fellow of ophthalmic surgeons. It's a great honor and even greater pleasure for me to deliver today's keynote lecture for two distinct reasons. One is the composition of our society, which provides friendship and link between American and European ophthalmic surgeons. And the other reason has to do with the location where we are coming together today. It's probably just a bit audacious to call our meeting the second most distinguished congregation in Cannes this year, surpassed in public recognition only by the Cannes Film Festival just a few weeks ago. While there's no Steven Spielberg, no Nicole Kidman amongst us, we can certainly do without the shrieking of fans and the shuttering of the paparazzi's cameras. We, as ophthalmic surgeons, do not strive for public applause, but for the well-being and gratitude of our patients. Many years ago, a gentleman from England, prematurely balding like two among us, came to Cannes on a regular basis just to paint. He put up his easel just a short distance away from where we meet today and created beautiful post-impressionist pictures of Cannes Harbour. He's not remembered for his paintings, though, which he simply signed Winston Spencer Churchill. The visitor who found new strength in Cannes and by painting is considered one of the greatest orators of the 20th century. Besides his eternal famous quotes about our finest hour and we will never surrender, he expressed a wisdom that could have sprung from the mind of us. We make a living by what we get, but we make a life by what we give. Giving back vision, restoring sight of people who have lost it, is one of the most rewarding professions I can think of, and I'm honored to talk to you today about ophthalmic surgery, which Churchill may also have had in mind when he said, "Success is not final. Failure is not fatal. It is the courage to continue that counts." It's a privilege for me to meet with you here yesterday evening, and you all will agree the standard of care is ultrasound phacoemulsification. It's indispensable, it's very well investigated, there are satisfactory outcomes, I think everybody will agree on, and we have low complication rate. So is there any reason to change? My answer is no, and I thank you for your attention. Well, unless you can use less or do not need it. Why? Because we all know, and it's very well documented, there is a heat issue. There are free radicals that are dependent in terms of the correlation of the ultrasound use. The more you use, the more free radicals, and they exert some oxidate and induce some oxidate tissue damage. And there are complications like endothelial cell loss, damage to the iris, alteration of the BAB, or cystoid macular edema. And we have coring at the tip, just as an example, post-occlusion surge, as my previous speaker already mentioned, wave propagation and thermal issues. So my personal experience with the laser cataract surgery in Bochum, where I'm working at the University Eye Hospital, is on a routine case, on a commercial base. We conduct 6 to 12 cases on 5 days per week. So it exceeded my expectations, but especially the difficult cases were facilitated, and I go into detail that to more extent. To understand what I'm saying is that we document prospectively everything. That means everything is HD recorded and prospective, documented by a medical doctor, Dr. Schulz here. The preoperative grades of the cataracts are performed by certified technicians. So LCS offers technical advantages, that is minimal ultrasound, pneumodissection, no or minimal hydrodissection with the free lens already, pre-fragmentation, which is then easier to perform the cataract surgery, and less manipulation. We found a significant reduction overall by just applying the 500 micron grid from this to this with the laser. This was the case over all grades, that means grade 2, grade 3 and grade 4, and you see that grade 4 is a little bit higher here because I'm more or less dependent on referring doctors operating outside and sending me their cataracts. Yeah, so we do 4,000 cataracts based on the university settings, and we compared manual versus laser, and you see in all grades, you see a tremendous reduction in effective phaco time by the order of 95% minimum. And the winners, from my personal perspective, are the patients suffering from cornea guttata or Fuchs dystrophy, because if you don't use ultrasound and do just aspiration, the cornea looks great. And it works. But what about the advanced cataracts? I'm talking about brunescent ruber cataracts. Well, still there, you will need some phaco. It's in the order of 2.2, which nicely compares to my manual group if I compare it to grade 3 in effective phaco time. That means that, and you see that most of the cases were below 1, that means that we soften the lens from grade 5 to grade 3 by this prefragmentation. But it's all about optimizations, just the selection. It's, for example, instrumentation, it's software, it's instruments with greater openings to aspirate, to get rid of other things that are implemented in the system, and change the phaco tip, for example, to achieve a full fragmentation and just aspirate it. So let's have a look at 200 blocks, that means 200 case blocks, that means my first 200 to 400 cases. And all these cases I'm showing and sharing with you are comparative. That means they have the similar grade cataract and have a wide pupil. So we begin with the 500 micron grid, and if you look in the y-axis, we had still 60% where I needed some phaco. Then we decreased the grid space, adjusted the surgery and the settings, and we went down to 40% where I still needed phaco. And then I've changed phaco tip, which was a big thing for me, and further adjusted. And for that 1000 to 1400 case, I personally was below 9% where I still needed phaco. And then that means 91% it's only aspiration now. When we looked at these 9%, it was a minimal use of EPT, just beforehand to go into the lens, and they all were advanced cataracts, grade 4 cataracts, as you see. So, of course, you may argue, what about the fluid turnover and the procedure length? So we looked at this in more detail on the prospective scale and looked first for fluid turnover, blue standard, green laser cataract surgery, and you see it's the same fluid turnover, about in the order of 90 millimeter per case. And also if you compare here standard versus laser in terms of the lens from suction on to wound closure, it's about 6 minutes. But still we need phaco, but that means that we need something, maybe also alternatives that allow us to not to use ultrasound, and that is when I looked into my last 100 cases, 3% I still needed phaco. So there is, for example, the Catapulse, which is, what is that? Well, it's a company that's called MedLogix, and they have a pulsed vacuum where you can change or vary the frequency, the intensity and the pores of the pulsed vacuum, and it has a completely round plastic tip, diameter is 1 millimeter. And in inner lumen, stepwise increases, so there is a lot of power behind this. It's like a magnetic tip, so to say. And the incision width is below 1.3. So I went over to Tijuana in Mexico to a friend of mine, and we performed the LensX pre-treatment, followed with this catapulse aspiration. It's just aspiration, and I was able to aspirate grade 3 cataract very sufficiently. So maybe that this is a niche product that fits for the dense cataracts where we still needed a little bit of phaco. So I perform it under sterile conditions if I'm opening the eye with the low IOP increase, liquid optic interface. Here are pictures from the OR. And because we saw that there is only minimal IOP increase in this group of 10 millimeter of mercury, and that means that we can deal with small pupils because they are interesting in terms of they come with other comorbidities like endothelium, blue sonules, dense advanced cataracts and so forth. So you see here an eye where there is a Mayugin ring in, and you do the capsulotomy, or you can do it with iris hooks like here, and with or without OVD. This is the case without OVD, as you can see here, the bubbles in the AC after lasing. So what about intumescent pediatric Marfan syndrome? Well, we discussed that yesterday already. It's a special issue. These were the cases without OVD, but without OVD you have this. The capsulotomy may be nice, and you see it's under pressure, the lens, in the intumescent cataracts, but there are aberrant shots. This is because the lens is that much under pressure and the anterior chamber is not stabilized. In this case, it may be even better, especially under pressure, to inject OVD first. The pediatrics, they have no lobics, but they are the winners, if you ask me. Because everybody of you knows who has done the capsulorhexis on a pediatric case, how hard and difficult it is. And you see that you have to target at a smaller diameter, and we are calculating this, but you see perfect capsulotomy, and the posterior capsulotomy can be adjusted according to the anterior capsulotomy. Yeah, so you can do this even with keeping the anterior highlight surface intact. Yeah, by pushing back the anterior vitreous, doing a small hole in the posterior capsule like you do in the back in the lens technology. And these eyes, my youngest kid was 2 weeks, of course do not dilate well, and you have to dilate the pupil to some extent. Also Marfan syndrome are the winners. Here you see an extremely displaced lens where I cut very close to the pupil margin, and this is the post-op finding, a well-centered IOL with the Seoni ring here in place. So, but what about evidence? I mean, these are only anecdotal stories. You know all these the trials that have been published. My personal problem with these trials is that they were not prospective, randomized, comparative, intra-individual. So we did all these trials, prospective randomized studies, different separate investigations. We found less EPT, as you have shown already, less inflammation in the order of 20% in the first day, less corneal thickening, less endothelial cell loss, and less capsular back shrinkage, which is important to talk about EPT, and better visual acuity. Just to go in detail, here you see y-axis laser flare, here the different time points, only a difference in laser flare on the day of surgery, but less corneal thickening, less endothelial cell loss in the order of 30%, which is close to whatever just published in ophthalmology. Less back shrinkage, very early and continuous. The visual acuity was only better in the order of 1 line during the first week. So the bottom line for me is safety, finally. We analyzed my first 1,273 cases, included pseudo-exfoliation dense cataracts, but took only the wide pupils because the small pupils are a different story. So I had 4 complications, and interestingly, 3 of them were because of my learning curve. So I had, when we video analyzed it, 3 of them were preventable. This anterior and posterior capsule tear nicely compared what has been published by Roberts, for example, and others is a little bit lower. In terms of laser cataract surgery, to conclude, we were able to fast adopt this, perform more than 2,000 cases now on a commercial base with a significant reduction of ultrasound. Again, 97 is only aspiration. It's for me the indication for challenging cases with comparable or even improved safety and outcomes. A totally new world to explore, including the simplification of complex cases, the improvement of already existing techniques like posterior optic buttonholing or back in the lens, and new techniques and applications we will discover and perform for the sake of and better outcomes for our patients. Thank you for your attention.